So right now, in a state-of-the-art hospital somewhere in the world, there's a $3 million MRI machine sitting completely idle.
Right. And it's not because it's broken.
No, not because it's broken, not because there aren't patients waiting. It's sitting idle because a highly trained radiology technician is literally sprinting down a fluorescent-lit hallway, trying to hunt down a specific doctor to physically sign a paper authorization form.
Which is just wild to think about.
It really is. Every single minute that machine is empty, it costs the hospital a small fortune. But, I mean, much more importantly, it puts patient diagnoses on hold.
Yeah, and it is a perfect example of how the most advanced technology on the planet can just be completely derailed by the simplest, most mundane administrative bottlenecks.
Yeah.
We tend to view healthcare, especially high-tech diagnostic environments, as these frictionless marvels of engineering. But the reality when you get down to the floor is, well, it's often a lot closer to organized chaos.
Okay, let's unpack this, because for this deep dive, we are stepping into a very specific role. Consider us your strategic healthcare operations consultants today.
Sounds good.
So whether you manage a massive logistics hub or lead a tech team, or you're just, endlessly fascinated by why complex systems fall apart, this is going to be incredibly revealing. We are taking a hard look at something called the H-CREM 2.0 enterprise framework.
Right, the H-CREM 2.0.
Yeah, which is this specialized diagnostic instrument designed basically to eliminate what it calls systemic process latency and protect institutional capability in really busy, stressed-out radiology departments.
And to put that in simpler terms, systemic process latency is really just the invisible delay baked into a bad system.
Like the technician running down the hall.
Exactly, the tech running down the hall instead of actually scanning a patient. And what makes this particular framework so powerful is that it refuses to just take management's word for how well things are running.
Yeah, it forces a confrontation.
It does. It intentionally forces a collision between the polished, theoretical metrics of the executive boardroom and the gritty, chaotic reality of the frontline clinical floor.
So let's start exactly where hospital leadership usually starts, which is the executive perspective. The framework uses this clinical operations maturity scorecard to grade a department's workflows.
On a standardized scale from 1 to 5, yeah.
Right, and we are talking about evaluating 8 strategic domains of operation here.
And to really understand the stakes, I think you have to look at the extremes of that scale. So a level 1 department is operating in what they call a reactive or fragmented state.
Meaning survival mode.
Total survival mode. The operation is entirely dependent on manual interventions. People just relying on their own non-standardized habits, immediate crisis mitigation. They're basically just fighting fires from the moment the shift begins until it ends.
Wow. So level 1 is essentially a system held together by duct tape and the adrenaline of the staff.
Pretty much.
So what does the promised land look like? What is a level 5?
Well, a level 5 is an optimized and governed state. So here, the workflows aren't just suggested, they're actually algorithmically monitored.
Okay.
The system provides real-time feedback, and it actually protects the sustainability of the process. So it is a proactive machine rather than just a reactive scramble.
Let's break down how a department actually gets there, because one of the first strategic domains that executives have to grade themselves on is called automated governance.
Right.
The goal here is to minimize reliance on informal staff coordination by creating these systematically gated authority pathways. But what does that actually look like on a busy hospital floor?
Well, think about what informal staff coordination actually means in practice. It usually means shouting across a room.
Oh, yeah?
Or, leaving a sticky note on a colleague's monitor. Or making 3 phone calls just to figure out who has the authority to approve a contrast injection.
Which is just pure friction.
Pure friction. So automated governance strips all of that away through software. When a specific protocol requires a doctor's approval, the system immediately pings that specific doctor's tablet.
Oh, that's smart.
Yeah, and crucially, it locks out the next step of the process until a digital signature is captured. So nobody is guessing who is in charge, and nobody is running down a hallway.
That makes total sense. I mean, it takes the burden of coordination completely off the human and just puts it on the system.
Exactly.
Which leads right into another domain that feels incredibly critical here, which is asset synchronization. This focuses specifically on those capital-intensive scanner bays, the big CT and MRI machines.
Those are money makers, yeah.
Right. And the goal is to synchronize multidisciplinary teams to minimize room turnaround variance and patient transit latency.
Because an MRI machine isn't just a clinical tool, it is a massive multi-million-dollar capital asset. If that bay is empty just because the transport team didn't know the previous patient was finished, I mean, the hospital is just hemorrhaging capacity.
I always think of it kind of like a commercial airline. If an MRI machine is a commercial jet, asset synchronization is the equivalent of making sure the gates, the baggage handlers, the fueling trucks, and the passengers are all just perfectly aligned.
That's a great way to look at it.
Because you cannot have a massive $3 million plane just sitting on the tarmac because someone couldn't find the boarding passes.
Right, but let's evolve that analogy a bit to fit a level 1 hospital environment.
Okay.
It's like that commercial jet is sitting on the tarmac, but instead of an automated control tower coordinating the fueling and the baggage, the pilot is literally hanging out the cockpit window, yelling instructions to the ground crew over the roar of the engines,
Oh my God.
while simultaneously trying to answer customer service calls on their cell phone. That is what a lack of asset synchronization actually feels like to the operator on the floor.
Wow. Okay, that paints a much darker picture of the friction involved. And obviously in healthcare, the stakes are way higher than just delayed luggage.
Much higher.
Which brings up the domain of quality optimization. The framework says a highly mature system has to instantly generate objective, immutable data logs of protocol adherence for formal JCI quality reviews.
Right, the Joint Commission International.
Yeah, for anyone listening outside of healthcare, JCI is basically the ultimate authority in healthcare auditing.
And anyone who has ever survived a JCI audit knows it is just a uniquely stressful event. Like, in a poorly optimized system, an impending audit means weeks of retroactive panic.
Just digging through old files.
Exactly. Administrators are frantically trying to assemble binders of handwritten logs, just hoping that technicians remember to initial every single paper form 6 months ago.
It's a complete scramble to prove compliance after the fact.
Totally. But an optimized system removes the human memory element entirely. Because of that automated governance we talked about, the digital signatures, the system-gated steps, the software is quietly building an unalterable mathematical truth of what happened during every single scan.
So when the auditors show up, there's no scrambling at all.
None. The data log is instant, objective, and immutable.
Okay, so if I'm a hospital executive, right, sitting in my very quiet, very calm, temperature-controlled boardroom, looking at this scorecard, it would be incredibly tempting to just assume everything is running perfectly fine.
Oh, absolutely.
I mean, I bought the software, wrote the manual, so I'm going to circle a bunch of 4s and 5s for automated governance and asset synchronization.
Of course. And leadership often suffers from what we might call proximity bias. If the spreadsheets on your desk show high patient throughput, you just assume the system you designed is functioning beautifully.
But here is the fundamental problem with boardroom scorecards. Executives often lie to themselves, even unintentionally. A perfect operations manual means absolutely nothing if the actual floor is descending into chaos.
Exactly.
So how do we find out what's really happening? We have to measure the friction on the clinical floor, which is where the framework introduces its second diagnostic tool, the frontline radiographer workflow pulse.
And this is where the framework really gets its teeth.
Right.
It takes all those lofty administrative concepts and translates them into the gritty reality of the radiography suite.
Right.
It asks the frontline workers to parallel test the executive assumptions by grading their actual day-to-day working conditions.
And it asks them to rate everyday friction points.
Hmm.
We're not talking about abstract corporate strategy here. The framework explicitly targets things like ambient noise distractions, continuous administrative phone loops during active scans, and the chaos of unverified patient prep.
Yeah, so put yourself in the shoes of a clinical operator for a moment. You are sitting at the control console of a CT scanner.
Okay.
You have a nervous patient on the table who needs the precise injection of contrast dye. Right as you are calculating the timing, a patient arrives from the ward with the wrong vascular access line, meaning you can't even inject the dye.
Yeah.
And at the exact same moment, the phone rings. It's the front desk, and they are confused about an insurance pre-authorization for a completely different patient.
That is insane. You are trying to perform a highly technical, potentially dangerous procedure, and you are basically being treated like a receptionist.
Exactly.
And this brings up a domain in the framework that I think is the most fascinating part of this entire deep dive: cognitive sustainability.
The huge one.
The framework defines this as ensuring specialized clinical operators are structurally isolated from distracting alert noise, clerical phone loops, and administrative bottlenecks during active patient cases.
Because why is cognitive sustainability a metric? Because the human brain is simply not equipped to rapidly context switch between life and death clinical calculations and mundane administrative troubleshooting without eventually making a catastrophic error.
Here's where it gets really interesting, though, because in almost every other corporate environment, we practically worship the ultimate multitasker.
Oh yeah, we reward it.
Right, we expend project managers and executives to juggle 5 different crises at once, and we consider it a badge of honor. So shouldn't we expect the same from highly paid medical professionals? Isn't handling pressure just part of the job?
Well, handling clinical pressure.
Yes.
Handling administrative incompetence, no.
Ah,
It's
right.
funny, we would never accept that kind of multitasking in other high-stakes environments. Take air traffic controllers, for example.
Right.
The FAA heavily regulates exactly how many hours they can work, mandates specific breaks, and structurally isolates them so they only focus on the airspace. No one asks an air traffic controller to also answer the customer service line for lost baggage.
Right, because if you break their concentration, planes crash.
Precisely. But in a hospital, we often just expect the radiographer to absorb the chaos indefinitely.
Just deal with it.
Yeah, but the framework argues that true process capability is defined right at the intersection where the clarity of the boardroom meets the execution of the frontline suite. If the operator is drowning in clerical noise, the system has failed, regardless of what the executive circled on their scorecard.
So we have these two completely different perspectives. We have the boardroom looking at pristine throughput numbers, and we have the clinical floor buckling under the weight of unverified prep and ringing phones. Yep. How does this framework actually reconcile those two worlds?
It demands a mathematical reckoning.
Oh, I like that.
Yeah, the framework doesn't just collect these surveys and file them away in a drawer. It introduces a critical data mechanic called the alignment equation. It calculates statistical variance to expose the actual truth.
Okay, walk me through the math here. How does the alignment equation actually work?
Well, the calculation is intentionally simple, so it can't be hidden behind, complex data science. First, you take the total overall score from the executive edition.
Okay.
Let's say leadership thinks they're a solid 35 out of 40, a highly optimized state. Then you subtract the total score from the frontline pulse.
The reality on the floor.
Right. Let's say the floor rates their reality at a 28, so delta equals score executive minus score frontline. In this case, your variance is 7.
So what happens when that variance is calculated? What does a gap of 7 actually mean for the hospital?
The framework establishes a hard, undeniable rule. A calculated variance score greater than 5 mathematically confirms an active visibility void.
A visibility void. That phrase alone is incredibly ominous. What exactly is falling into this void?
The truth. The truth about how the work is actually getting done. What's fascinating here is that it dissects the psychology of hospital management.
How so?
When you have a visibility void, it proves that your pristine boardroom utilization metrics are actively masking systemic process leakage.
Wait, let me make sure I'm getting this. So the executives are looking at their spreadsheets. The spreadsheets say 50 patients were scanned today. So the executive thinks, great, our automated governance and asset synchronization are working perfectly.
Right, but what the alignment equation reveals is that the system didn't scan 50 patients. The staff scanned 50 patients by utilizing exhausting, heroic workarounds. They ran down the halls, they answered the phones while calculating doses, they double-checked the wrong vascular access themselves. The executives are measuring the sheer willpower of their frontline workers and mistaking it for system health.
That is a massive distinction. So the system itself is broken, but the human beings are acting as the shock absorbers. They're taking on all that friction so the metrics still look good.
Exactly. And human shock absorbers eventually break. The framework specifically identifies this visibility void as the prime driver of unmeasured staff attrition.
Meaning burnout and people quitting.
Yes. When your daily reality is chaotic and exhausting, but your leadership insists everything is optimized, it creates this deep cognitive dissonance. You burn out. You quit. And leadership is left completely baffled as to why they have a retention crisis among their most highly skilled technicians.
Man, think about the validation this framework provides for a frontline worker.
Oh, it's huge.
For years, you might complain in the break room that management has no idea what it's really like down here. Now you have an objective mathematical equation that proves it. It elevates those complaints from just anecdotal grumbling into a quantified institutional vulnerability.
It really forces leadership to confront the friction they've inadvertently created. But, diagnosing a visibility void is only half the job of a consultant. We also need to know when a system is so structurally compromised that it requires immediate intervention.
even if the overall scores look okay on paper.
Exactly.
Right, because you could technically have a low variance, say both the executives and the frontline agree the department is a 20 out of 40, but there could still be fatal flaws hidden in that average.
Yeah, absolutely. And that is why the framework implements what it calls systemic red flag triggers. But to understand this, you first have to look at the total operational performance spans.
Which the source material breaks down pretty clearly. So if a department scores between 0 and 15 total, they are in a state of severe structural vulnerability. They are heavily dependent on those unsustainable, ad hoc human efforts just to survive the day.
Right.
On the flip side, 33 to 40 is the standardized or optimized state. That's where structural process latency is actually managed and cognitive conditions are protected.
But the red flag trigger supersedes those total scores completely. It's essentially an emergency brake.
Okay, how does it work?
The rule states that if a department registers a score of 2, which signifies an emergent or variable state with process leakage or lower in any of 4 foundational anchors, it mandates an immediate clinical workflow remediation review.
So even if your overall score is a 35, if you bomb one of these 4 pillars, the whole system grinds to a halt for review.
It has to, yes.
So what are the 4 pillars that carry that much weight?
They are automated governance, horizontal visibility, cognitive sustainability, and platform integration.
Okay, we've explored governance and cognitive sustainability already, but let's look closely at platform integration. In a hospital environment, what platforms are we actually talking about integrating, and how does a failure here trigger a red flag?
So we're primarily talking about the 3 main technical ecosystems in healthcare.
Oh, right.
There's the RIS, which is the Radiology Information System handling, scheduling, and tracking. The PACS, which is the Picture Archiving and Communication System, where the actual images are stored.
Right.
And the EHR, the overarching electronic health record that contains the patient's entire medical history. Platform integration means these systems interoperate seamlessly without requiring manual data duplication.
So if a hospital scores a 1 or 2 in platform integration, it means those massive, incredibly expensive software systems literally do not talk to each other.
They're isolated silos, yeah.
So where does the burden fall when that happens? What actually happens to the patient in that moment?
The burden falls entirely on the radiographer. If the systems don't talk, the clinical operator is forced to act as a human software bridge.
A human software bridge? That sounds terrible.
It is. They have to open the EHR on one screen, read the patient's medical history, note any severe allergies to contrast dye, and then turn to the RIS on another screen and manually transcribe that data.
That sounds incredibly tedious, but more than that, it sounds incredibly dangerous.
It is the absolute definition of clinical risk because every single time a human being is forced to manually transcribe critical data, you introduce a window for error.
Right.
And remember the conditions we established earlier. This isn't happening in a quiet room. The radiographer is doing this manual data entry while the phone is ringing, the ambient noise is high, and they are context switching back and forth.
So a failure in platform integration completely destroys cognitive sustainability. They just cascade into each other.
Precisely. Without these 4 structural pillars functioning together, you cannot optimize the system. It fundamentally disjoints the operation at both the data level and the human cognitive level.
Wow.
The H-CREM 2.0 blueprint makes it very clear. A crumbling foundation will eventually bring down the entire house, no matter how nice the executive scorecard looks on the surface.
This deep dive completely reframes how we should look at operational success. I mean, the true mission of this framework isn't just to make a hospital run faster or to boost some arbitrary throughput numbers.
Not at all.
It's about bridging the massive, dangerous gap between administrative theory and clinical reality. It's about aggressively hunting down the process latency that drains hospital resources. And really, above all, it's about protecting the cognitive focus of the people who are actually doing the life-saving work.
Yeah, it forces leadership to strip away the illusion of pristine engineering and replace it with actual verified alignment between the people designing the systems and the people surviving them.
And for you listening, whether you are anywhere near healthcare or not, the lessons here are universal. The principles of demanding automated governance, of insisting on platform integration, and protecting the cognitive sustainability of your team, that applies to any high-stress environment. Unseen friction is the enemy of every complex operation.
Which leaves us with a really critical question to take back to your own desk today.
Yeah.
Think deeply about the visibility void in your own industry. If an alignment equation variance of just 5 points can reveal a hidden disaster in a highly regulated hospital, what might happen if we applied this exact mathematical formula to your workplace?
Are the pristine utilization metrics and the glowing quarterly reports you present to your boss actually reflecting a healthy system? Or are they actively masking the daily operational friction, the manual workarounds, and the heroic chaos that is burning out your team right now? It might be time to find out what your own frontline really thinks.